Professor and my dear students. Today we have another session of Raisa DNB academic activities online. Today we have a case discussion on code flu, that is a cardiac arrest situation after spinal anesthesia. So followed by discussion with Professor on IV fluids and drugs. The session is for 2 hours. Now I request Professor to carry forward the session, sir. Thank you, sir.
Yes, Dr. Preeti, you can start the case presentation.
Yes, sir. So good evening, sir. Today my case scenario is a 24-year-old male posted for inguinal hernia repair. Soon after giving subarachnoid block, patient develops cardiac arrest. So how will I proceed? This was the question. So according to ACLS guidelines, first I will check the response of the patient by asking loudly, "Are you okay?" If patient is unresponsive or not following verbal command, I will ask for help, and simultaneously I will look for breathing and pulse. I will not be taking more than 10 seconds for this. And if there will be no pulse or no breathing, then immediately I will start CPCR and will activate emergency system, code blue. And till the help arrives, I will continue CPCR in a ratio of 30 to 230 chest compression to ventilation at a rate of 100 to 120 per minute. Then after giving 5 cycles of CPCR, I will assess the rhythm. If it is shockable or non-shockable rhythm. If it is a shockable rhythm, like ventricular fibrillation or pulseless ventricular tachycardia, then I'll instantly give shock at a 120 to 200 joules, and will continue the CPCR without interrupting, with minimal interruption. And at the same time, I will consider giving injection epinephrine 1 mg followed by 10 ml saline. And during assessment, I will consider advanced airway placement like endotracheal tube or supraglottic airway device. And if the rhythm is non-shockable, then I'll give injection epinephrine 1 mg followed by 10 cc NS bolus, and will continue CPCR. And then again after 2 minutes, I will assess the rhythm if it is shockable or non-shockable. If rhythm is shockable or it is refractory to shock or adrenaline, then I will consider injection amiodarone or lignocaine. Injection amiodarone in a dose of 300 mg bolus, and second dose will be 150 mg, or injection lignocaine. Loading dose will be 1 to 1.5 mg per kg IV, and maintenance dose will be 0.5 to 0.75 mg per kg IV. At the same time, I will try to identify the reversible causes and will try to treat it. If after the adequate time, after 30 to 40 minutes, if there is no signs of 30 minutes, if there is no signs of return of spontaneous circulation, I'll continue the CPCR. But if there is signs of return of spontaneous circulation, I will consider post cardiac arrest care. uh, if return of spontaneous circulation obtained, then I will manage the respiratory and hemodynamic parameters. Like I'll start 10 breaths per minute with positive pressure ventilation. I will maintain FiO2 to, I will give FiO2 to maintain SpO2 between 90 to 98%, and PaCO2 to maintain between 35 to 45 mmHg. And to maintain hemodynamic parameters, I'll maintain systolic blood pressure more than 90 mmHg, and MAP, mean arterial pressure, more than 65 mmHg, by using IV fluid and vasopressor like noradrenaline in a dose of 0.1 to 0.5 mics per kg per minute. And at the same time, I will obtain 12-lead ECG and X-ray to rule out any lung injury, pulmonary edema. And after that, I'll see the patient is following command or not. If patient is following command and he is awake, then I will try to find out the reversible causes 5H and 5T, and then I will try to treat it, and will monitor the patient till he gets stabilizes. Or if there is no patient is not awake and he is comatose, then I'll obtain brain CT at the same time, will monitor EEG, and will manage other uh, I will try to find out and manage the patient. So that's it.
Have you finished, Dr. Preeti?
Yes,
Okay. Am I audible?
yes, sir.
Okay. Good. You have done a good presentation. Now, what are the types of life support you know of?
So basic life support and advanced cardiac life support and compression only life support.
The first and foremost thing is compression only, COLS. Okay. Why COLS has been introduced? When was it introduced?
Sir, I don't know, sir, when it was introduced, but it was introduced for
Is it introduced
low.
after the BLS and ACLS, or is it introduced before BCLS and ACLS?
Sir, after ACLS and BLS.
It is quite recently, about 2 years ago only, COLS was introduced. Can you just tell why it was introduced? For what purpose?
Sir, it was for the lay rescuers.
Yeah, very good, very good. It is for the lay rescuers who are not fully trained in complete BCLS and BLS and ACLS. What is CCLS? Do we call it as ACLS now or CCLS now?
So CCLS is comprehensive cardiopulmonary life support.
Okay. So what is the difference between CCLS and ACLS?
Sir, this is for doctors and paramedics to resuscitate cardiopulmonary arrest victims in the hospital. In this, the components of CCLS is early recognition and management of pre-arrest condition, which is not available in ACLS. ACLS is after diagnosis of cardiac arrest.
So what are the other core links you know of?
Sorry, sir?
Adult core links. What are the links that you have to follow in a resuscitation guideline?
Sir, there are 6 links according to LACS. ACLS. First is early recognition and prevention. Second is activation of the emergency response. Third is the high quality CPR. Fourth is the defibrillation. Fifth one is the post cardiac arrest care, and sixth one is the recovery.
Where is
Recovery
the
is
early
the
transfer coming? It is out of hands to cardiac arrest. The early recognition and activation, early high quality CPR, early defibrillation, and early transfer. If it is the out of hospital cardiac arrest, then these are the 4 chains in the link. Okay.
Yes.
Early recognition and activation, early high quality CPR, early defibrillation, and early transfer to a nearby hospital. What is the meaning of early high quality CPR? What do you understand by the term?
Sir, high quality CPR is the CPR we are giving the compression of adequate rate, which is 100 to 120 per minute, and adequate depth of 5 centimeters, and in which we are allowing the chest to complete recoil between compressions, and in which we are minimizing the interruption between chest compressions, avoiding excessive ventilation, and rotating compressor every 2 minutes. This is called as high quality CPR.
Okay. This 120 rate per minute, do you give it continuously or in a different pattern?
So we give it like 1 and 2 and 3. So in which the number is the compression and is the relaxation.
It's given in cycles of 30 compressions. Okay. So you have to give it in 30 compression sets and then interrupt it for 2 breaths. Again 30 compressions, 2 breaths, like that you have to give. Okay. So you have this 120 has to be split into 4 cycles, 30 compressions. And every time you do that, your elbow should be straight. You should give it on the lower part of the sternum. And the person who doing the rescue should shout 1, 2, 3, 4, 5, 6 so that everybody can follow the count and make sure that the number of compressions are being carried out. Okay, all these things are also included in this high quality CPR. It is not only the depth that you make, but it is also the number of cycles and the way you count it and the way you press it, where you place your hand. All these things have to be spread. Okay?
Yes, sir.
So these are all the most important things. And supposing the compression only life support is done by a bystander. Okay, he is not a medical person or a paramedic. What is the immediate treatment that or the help that should be offered to the victim? The person who has seen some in video or in some training program how compression is given, and he has seen a person who has fallen down with a cardiac arrest in a mall or in a market. Okay, and a bystander has started the resuscitation. What is the immediate thing he should be knowing to do apart from the compression? What else he should do? Or what else the public should be taught of if you are going to demonstrate compression only life support to the public? You are going as a trainer to a school or a college to teach people how to do compression only life support. What are all the things you will tell them apart from how to do the chest compressions?
So first of all, we have to verify the scene safety. I will tell them to not to perform CPR on the place first. You should verify the scene safety. It should not be at the place which is dangerous for the bystanders, like toxic or electrical hazard to the bystanders. And then I'll tell them to how to check for response by tapping on the shoulder in front if patient is responding or asking loudly, are you okay? Are you okay? If patient is not responding, then check for pulse or breathing by keeping hand on chest or by keeping two fingers at the nose. If a patient is not breathing, then he can start CPCR
Okay.
uh,
A
by 30
person,
compressions.
a person has fallen down and is unconscious, he is not responding. What are the three types of presentation he can have with regard to his cardiovascular and respiratory controls? One category is there is no respiration, there is no pulse. Okay. Another category, there is a pulse, but there is no respiration. The third category, there is a pulse, but there is a poor respiration. These are the three case scenarios that they come across. What should they do? Or what do you teach them? So there are three
Sir,
categories. Right.
if there is pulse, if there is pulse and respiration, then I'll ask them to observe the patient and shift the patient to nearby medical care unit.
Very
Or
good.
if patient is not having pulse and poor
Now, patient is having pulse but no breathing. See, in the
patient
first
is
case
having
scenario, there is a pulse, but there is a poor ventilation. There is a breathing, but it is inadequate. This is the first scenario. Second scenario, he is able to feel a pulse, but patient is not breathing. Third scenario, the pulse is not felt, no respiration also is seen. So what should you do in the first case scenario where there is a pulse and some poor breathing? You can shift him to immediately to the nearest available medical center, number one. That's right. The second scenario, there is a pulse is felt, but there is no breathing. What should they do?
sir, they should ventilate.
Give respiratory support. Okay? Give rescue breaths. How many times a minute? What is the frequency?
So 30 two
Breath,
two breaths.
respiration alone, mouth to mouth or mouth to nose respiration. How should they give? They should give it one breath for every 5 seconds. That is 12 breaths per minute. Okay?
Okay.
And they should reassess after every 2 minutes whether the patient has started breathing spontaneously or not. The third category is one where there is no pulse or there is no respiration. You go first for compression, then you go for rescue breathing. Okay, so this is how the bystander or the lay people should be taught. 3 types of case scenarios: pulse is present, respiration is present but inadequate. Immediately try to shift the patient to the nearest hospital. Second category: pulse is present, no respiration, only rescue breaths at the rate of 1 in every 5 seconds or 12 breaths per minute for continuously 2 minutes and reassess the patient. Third category: there is a breath, there is no pulse, there is no respiration. Start first compression, then at the rate of 30 cycles, 30 compressions for one cycle, then two rescue breaths, again 30 compressions, all these things within 1 minute. Okay, so like that you have to resuscitate, and that is how they should be taught. So when you said about defibrillation, what are all the precautions to be taken with giving early defibrillation? Supposing you find you have attached the ECG, you find it is a shockable rhythm. So before shocking the patient, what are all the precautions, or what are all the steps you have to follow?
Sir, before shocking, first I will charge the defibrillator, and when defibrillator is ready, I'll ask everyone to keep away from the bed, and will shock the patient. Like I will ask all clear, and then
What is the strength or the how many joules you will keep?
if it is biphasic defibrillator, then I'll give 120 to 200 joule initially. After that, I can increase the current. And if it is monophasic, then I'll give 360 joule.
Very good. Where will you place the paddles?
Pardon me?
Where will you place the paddles of the defibrillator?
The paddles is anterior on the sternum and laterally on the at the apex.
Anterior and the
Intercos anterior laterally.
What do you mean by anterior and lateral? There are exactly two positions described. One is below the right clavicle, right infraclavicular area. Okay. The second one is at the apical region or the apex of the heartbeat. That will be in the fourth intercostal space on the left side. So it should be between the right infraclavicular area and the left fourth intercostal space. That is the two positions where you keep. Sometimes people, if have any problem like pneumothorax or anything on the right side, you can keep it on the apex and the back also on the infrascapular region. Okay? So you want the current to pass right through the heart muscles. So how does defibrillation help in reverting the heart to the sinus rhythm?
The defibrillation, it involves the delivery of current through the chest and to the heart to depolarize the myocardial cells simultaneously and to eliminate ventricular fibrillation of ventricular tachycardia.
So it tries to overpower the natural electrical power of stimulus. Okay? So by giving a higher current or a higher energy, you try to overpower the small miniature electrical potentials and try to stimulate the SA node and try to take it back to the sinus rhythm. Okay? So these are all the points that you have to remember with regard to this thing. You have done a good job. So shall we go on for the other things now? Kamachi? Shall we go for
Move on to the next session, sir.
Huh?
Can we move on to the next session, sir?
Yeah.
Yes, please.
Start sharing this. Are you able to see?
Sir. Yes, sir.
So, like last week, when we discussed about the machine, this discussion on drugs used in anesthesia and IV fluids cannot be covered in the short time that we have available. So I have just prepared a presentation like a random selection of few drugs and how to go about it in the Viva. So examiners in the Viva examination, they may give you a choice to choose the drug, which may be kept in a tray in front of you, and they will ask you to describe about it. That is so you can consider yourself lucky and you can start describing all the points that you know about the particular drug which you are very familiar with. On the contrary, they may also give you, select the drug themselves and give it to you and ask you to describe that. The third option is they may just ask a few questions on a particular drug without asking you to describe in your own method. So whatever it is, when you want to describe a drug that is given to you in the exam, first of all, read the label and identify what is the drug. It will have a proprietary name and it will have a generic name. Okay, and you first identify and try to familiarize yourself what category of drug that is. Then you first read out the name and the presentation. Some drugs may be present in a liquid form. Some drugs may be present in powder form. Some drugs may be manufactured and marketed in a vial. Some drugs may be marketed in ampoules. So first you describe. Supposing you are given a bottle of scoline, you say this is hexamethonium, and also always read the salt preparation also. This is hexamethonium chloride, available as 50 milligram per ml in 5 ml vials or 10 ml vial. That is what first you have to say. Or if they give you a thiopentone vial, maybe you have to say this is thiopentone sodium, available as 500 milligram powder for reconstitution. This is a intravenous short-acting induction agent, and you will start describing all the things. But if the examiner straight away asks you some question on thiopentone, why it is marketed as powder, then you have to answer that question straight away. So these are the three types of questioning that you may get. Choosing a drug and asking you to describe yourself everything about it, or the examiner selecting and giving you the drug and asking you to prescribe, or examiner giving you the drug in your hand and then asking straight away some questions on that. Okay, so I have prepared the questions in such a way that it is the third category. And I have chosen the points which are not given in the books because you can read them up. Some of the points which are not available in the books and which are asked by the examiners. So I have selected such points and made questions on that to make you have a good idea about how to manage those questions in the examination. Okay. So let's start the presentation. So there are a few categories of drugs which you have to know before you would go for your exam. They can be classified as induction agents. All of you know that you have been using propofol very regularly in your training period, or you must have used thiopentone occasionally, and more rarely you would have come across using etomidate or ketamine or dexmedetomidine, all these drugs for your induction. So the common induction agents, all of them you must know. You must know all about analgesics, which may be opioid or non-opioid. You must know all the pharmacology about the local anesthetic agents. You must know everything about your muscle relaxants and the reversal agents. And you must know the sympathomimetics and inotropes which are used mainly in the ICU settings. And you must know about the adrenoreceptor antagonists like NTG or SNP. And you must know antiarrhythmic drugs which are used occasionally especially in the ICU or intraoperatively. And you must know something about the antihypertensive agents. And you must know the pharmacology of anti-epileptic drugs also, which are useful sometimes, and everything about antiemetics, which are commonly used in our day-to-day practice, and diuretics. So these are the 12 categories of drugs which are very, very essential for your exam point of view and also from your future practice point. So I have selected a few drugs from all these categories so that it will be just like a random preparation for your examination. So we start with the intravenous induction agents. First thing is thiopentol sodium. How many of you have used thiopentol sodium? Anybody who has not used thiopentol? Can unmute and say whoever is not used. You can unmute and say I have not seen, I have not used thiopentol sodium. I want this to be a more of an interactive session rather than a didactic lecture. So whoever knows the answer, please unmute and you can answer. Or Preeti, if you are available on mic, you can also answer this. Have you used thiopentol sodium? Dr. Preeti?
No, sir, we don't use regular.
Have you seen the vial at least?
Sir, I have seen the vial, but I haven't
You have not had the chance to use at all. Very good. Okay, but this is one of the common drugs which will be kept in the exam. So examiners expect you, especially a little older examiner, they will be very fond of this drug because they grew up with this drug rather than propofol. So it is a must that all the students, whether you have used it or not, it is better that you read about this drug in toto. And I am going to just give you a glimpse of a few points which the examiners eagerly want to know from you. So what is thiopentol sodium? It is a sulfur analog of oxybarbiturate pentobarbital. What are the preparations or the strengths in which it is available? Any idea? Rajesh, are you there? Any other person who has used this or seen this? Do you know what are all the strengths or the dosages or the total amount of drug that is available and presented in the market? So it is available.
Two type of vials, sir. One vial containing 500 milligram, one vial containing 1 gram, sir.
Excellent. Who is that?
And it has to be diluted with 25 ml of the saline, sir. So it comes around to 2.5%, sir.
This is 20 ml, not 25 ml. If you put
20 ml, sir. 20
if you
ml.
put 10 ml in this, it
20
will be 500 milligram, 50 milligram in 1 ml. Okay. If you put 20 ml, it will be 25 milligram or 2.5%. So these are the two strengths that are available, and it is marketed as what? As a powder, isn't it? Why it is marketed as a powder? That is the next common question examiners are very fond of asking.
Yeah, it's a yellow amorphous powder because of sulfur, sir. And it is an environment of the nitrogen, sir.
It's not because it is made of sulfur. Some other reason is there. See, when you reconstitute it with diluting it with water, what is the pH of the solution?
It's around 10.
It is highly alkaline. So alkaline solutions will not stay or will not retain their potency in room temperature for more than 24 hours. Okay. So if you have prepared, if you have taken this 500 milligram vial and put 10 ml or 20 ml water and dissolved it, and you use only 4 ml or 5 ml for a case, the remaining 15 ml which you keep in the vial has to be used within 24 hours. If you keep it beyond that, it may lose its potency. So if it is marketed as a liquid, it will have a high alkaline pH and it will not be able to have its potency in room temperature. So all drugs which have an alkaline pH, when they are in solution form, will be marketed only as powder for reconstituting it into a solution at the time of use. This is the answer that is expected out of you. And the immediate next question that will follow is, what are all the other drugs in your practice you have seen which are marketed as powder?
Becuronium.
Excellent. Becuronium. Okay. Any other drug? Have you used hydrocortisone?
Methylprednisolone, hydrocortisone.
Methylprednisolone, hydrocortisone, all these drugs which are all marketed as powder form all have a alkaline pH when you dissolve them with water or whatever solution that you use. Those drugs which have an alkaline pH after the reconstitution will be marketed only as a powder for keeping them in the shelf or there to maintain their shelf life at least for 1 or 2 years. Okay, so that is the answer that is expected out of you. But then common question is, it is a barbituric acid. Dipentone is a barbituric acid. How is barbituric acid formed? Any idea? It is formed by the combination of urea and malonic acid. Okay, this will give rise to barbituric acid and water. This is the main constituent in the dipentone. How is it marketed and why? Already whoever answered the first question, he said it is in an atmosphere of nitrogen. Inside the bottle, it is not air or vacuum. It is filled with nitrogen. And it has got another component in this powder. It is not only dipentol sodium or oxybarbiturate, but there is another constituent in the powder. Any idea what is it? It is a pale yellow powder which has sodium carbonate, Na2CO3. 6% sodium carbonate is there in the powder, and it is in a nitrogen atmosphere. The bottle is filled with nitrogen. Why? Why it is filled with nitrogen instead of air? All the other vials which you are filled will have air in this space, top space. But this dipentone vial is filled with a nitrogen atmosphere. The reason for that is this
Prevents
sodium
precipitation.
carbonate.
Prevents the precipitation of insoluble acid formed by atmospheric carbon dioxide.
Very good. So what does sodium carbonate do? This is the reaction. The sodium carbonate will react with water and it will form soda bicarb, sodium and hydroxide, resulting in a strong alkaline solution. This is the reason for its alkalinity. When you mix it with water to dissolve this powder, the sodium carbonate becomes sodium bicarbonate and it becomes sodium and hydroxyl ions. So this gives the alkaline nature, whereas the nitrogen is used instead of air because if you use air, the carbon dioxide in the air will react with water vapor and form carbonic acid. And carbonic acid which will easily break down into bicarb and hydrogen ion, and it will reduce the alkalinity of this powder. Then the powder will not properly dissolve. So in order to make it more soluble in water, they remove the air and fill it with nitrogen. So remember the answer that it is the nitrogen is used instead of air to remove the carbon dioxide which will be in the air, so that the powder will be easily made into a solution with water. And is there a tautomerism character in dipentone? Any idea what is tautomerism? And what is the other name for tautomerism? Have you heard this term tautomerism with some other drug which you commonly use nowadays? Any of those who have post DA secondary candidates going for exam next month? Tautomerism is also called dynamic isomerism. Okay, a drug which has got one particular property when it is in the vial, when it is injected into the body, it takes some other property or becomes some other character, achieves some other character. So there are two forms, keto form and enol form for these drugs which exhibit this tautomerism. So thiopentone has got the soluble enol form and less soluble keto form. So it can become from less soluble keto to soluble enol form when you try to dissolve it. So it exhibits tautomerism. Similarly, midazolam is another drug which we nowadays use, which also exhibits tautomerism. Midazolam, when it is in the vial, it is a water-soluble compound. So it is less irritant and less painful on injection. Once you inject it into the body, when it reaches the blood and at the blood pH, it becomes unionized and it is able to immediately penetrate the neurons and produce an immediate action. That is why it is faster acting. Okay. So when it is in the vial, it is unionized. It cannot penetrate at the time. But when it is injected into the body, it becomes, it is ionized in the vial, and once you inject it into the body, it becomes unionized and immediately able to penetrate the neuronal cells and produce its action. So two drugs you can remember, one is thiopentone, another is midazolam, which also exhibits tautomerism. The other name for tautomerism is dynamic isomerism. Dynamic means it changes the configuration or its chemical formula. So what is the effect of thiopentone on respiration? That many of you say that you have not even seen or used this drug. When you inject the drug, what will happen? In one arm brain circulation itself, it will produce unconsciousness. It is such a fast-acting drug. In one arm brain circulation, it will make the patient unconsciousness will set in, but patient will not be totally asleep. He will have an initial depression of the respiration. And so the respiration will become more and more shallow as you keep injecting the drug. The dose of the drug is about 4 to 5 milligram per kilogram body weight. So for a 70 kg man, if you take 350 milligram, that means if you put 10 milligram, 10 ml of water in this, you will get 50 milligram per ml. So you have to take almost 7 cc of that. So 7 into 50 will be 350. So 350, as you slowly inject, by the second ml or third ml, patient will be completely sleeping. That is called sleep dose. After that, during that time, the respiration will gradually become shallow. And at the completion of the 350 milligram calculated dose, patient will take a deep breath and become totally apneic. So there are two depressions: initial shallow respiration followed by a complete apnea. So they call this effect as a double apnea. Okay, patient becomes twice apneic. So it is called double apnea. So some of the old-time examiners are fond of asking this effect on the respiration by thiopentone. So if you say this answer, you are likely to get good marks in your examination. So what is the absolute contraindication for usage of thiopentone? This is another important question everybody should know. Any idea?
Porphyria.
Porphyria. Very good. Porphyria is where it's absolutely contraindicated, as it can precipitate an acute porphyric crisis where patient will have severe muscle cramps, abdominal pain, and even unconsciousness will set in. What are the other drugs which can cause similar porphyria or contraindicated in porphyria apart from thiopentone? So that may be the next question if you answer this correctly. So porphyria is the condition where you should not use thiopentone. It's an absolute contraindication. Other drugs which have to be avoided, like other barbiturates, etomidate also should not be used. Halothane should not be used. Cocaine, lignocaine, bupivacaine, all local anesthetic. Clonidine, metoclopramide, iosine, diclofenac, rallietidine. All these things have to be avoided in porphyria. Now coming to this drug, which is very commonly used nowadays, what is the chemical name for propofol? All of you should be very, very familiar with this drug. So this is a very
Isopropyl phenol.
Very good. 2,6-diisopropyl phenol. Excellent. What are the preparations? What preparations are available? What are the strengths in which you get propofol?
1% and 2%.
Very good. Very good. Very good. You have 1 gram in 100 ml big bottle. You have 500 milligram in 50 ml. You have 200 milligram in 20 ml. So this is the one commonly you use for your induction. What is the purpose of this 50 ml and 100 ml?
For infusion, sir.
For total intravenous anesthesia or ICU
Yeah.
sedation. Okay.
Yeah.
So the larger bottles are used for TIVA or ICU sedation purpose, whereas the 20 ml bottle is commonly used for in the theater for induction before anesthesia. So what is the PK of propofol and what is its advantage? What is the advantage of it? All of you are very familiar with propofol, using it every day. So the PK is 11, and at this PK it is almost entirely unionized at the body pH of 7.4. So it can enter the neuronal cell membrane easily and rapidly induce the patient. Okay, so the faster onset of action of propofol is because of its high pKa, where at the body pH of 7.4 it is almost 90% unionized and able to immediately penetrate into the central nervous system and produce the unconscious lead. Why is it marketed as an emulsion? It is not a clear liquid like other drugs. It's a milky white thick liquid, isn't it? It's called an emulsion. What is an emulsion?
Oil in the two phases of liquids or gas mixed together. Two states of compounds are mixed together, emulsion. It's like oil and water.
Emulsion is a mixture of ester and then alcohol. Okay, so it is a mixture of ester and alcohol. Of course, you can say oil and water also, something which is much thicker and some liquid which is less thicker. So it is an emulsion. But why it is marketed as an emulsion? Because the propofol powder, the 2,6-diisopropyl phenol, is not soluble in pure water. Okay, so it is made as an emulsion. What are all the constituents that make it into an emulsion? It is soybean oil and purified egg lecithin. Okay, these two are the ones which make it into an emulsion. What is propofol infusion syndrome and who are the people who are at the risk of developing this?
Propofol infusion syndrome is seen when propofol is given in infusion for a long time, 24 hours, at a dose 4 milligram per kg body weight. And it is commonly seen in children, particularly in ICU and critically ill children, sir.
Very good, excellent. Okay. So common presenting features of propofol infusion syndrome are new onset metabolic acidosis, cardiac dysfunction, rhabdomyolysis, renal failure, and hypertriglyceridemia. So this is the first answer you should say. What is propofol syndrome? Propofol infusion syndrome. It is a cluster of clinical things which happen: new onset metabolic acidosis, cardiac dysfunction, rhabdomyolysis, renal failure, and hypertriglyceridemia due to continuous infusion of propofol for more than 24 hours. The risk factors for developing this are severe head injury patients when you try to give it as a protective mechanism for decreasing the cerebral metabolism and decreasing the oxygen demand, or patients who are in sepsis, or when the patients have exogenous or endogenous catecholamines, glucocorticoid level, low carbohydrate or high lipid intake, or patients with inborn errors of fatty acid oxidation, or pediatric patients. Actually, it was first described only in pediatric patients who received a continuous infusion. Okay? So these are the points, please remember about. So I am not going about all the other common points or the features which are all given in the book. So I thought I will select only those points which are asked by examiners which are not given in the books. So you will find more questions like that. Now coming to ketamine hydrochloride, I think all of you should be familiar with this. So again, what is the chemical group where ketamine belongs to?
Cyclidine group, sir.
Cyclidine
Excellent,
derivative.
excellent. It's a phencyclidine derivative. Excellent, very good. And what is the chemical name for ketamine? Examiners are very fond of asking what is the full chemical name of ketamine. And this is the molecule is called as 2-mo-chlorophenyl 2-methylamino cyclohexanone. 2-mo-chlorophenyl 2-methylamino cyclohexanone is the name, chemical name for the ketamine molecule. How is it presented for clinical use? What are all the preparations that are available?
1%, 5%, and 10% concentration.
Very good. So you have 50 milligram in 1 ml, you have 100 milligram in 1 ml, and you have 10 milligram in 1 ml. So these are the 3 vials which are available. This may be 10 ml vials. So 10 ml containing 500 milligram, which is 50 milligram per ml, which is 5%. You have 10 ml, 100 milligram per ml, which is 10%, or you have 1%, which is 10 milligram per ml for pediatric use. Any other preparation other than the 3? What is this? What is the difference between these 3 bottles and this one?
Preservative free.
Excellent. This is
For,
preservative free, which
final.
can be used for
Subarachnoid
intrathecal or epidural. Okay, so when you want to add this to caudal anesthesia in children, you have to use only this because this does not have any preservative. What is the preservative added in these 3 bottles, which are not supposed to be used for intrathecal or epidural use?
benzethonium chloride.
So when you say benzethonium chloride, excellent,
Ben-
excellent, excellent. So what is the type of anesthesia produced by ketamine? How can it be demonstrated that it is producing the type of anesthesia? What do you call the type of anesthesia produced by ketamine?
Dissociative anesthesia.
Excellent. What do you understand by dissociative anesthesia?
Yes.
Which one is dissociated?
Thalamocortical and limbic.
Thalamus is
It's
dissociated from
thalamocortical and limbic system. So there is
System.
a discontinuity or dissociation between the thalamus and cortex to the limbic system. Okay, and if you take an EEG, you can see the dissociation. Okay, so it can be demonstrated only by taking a electroencephalogram, not an electrocardiogram. So dissociative anesthesia is the dissociation between thalamocortical and limbic systems in the central nervous system, and it can be demonstrated by EEG. What other mechanism of action does ketamine possess apart from normally it is an NMDA antagonist? That is what we call it as. What is NMDA stand for?
Methyl D-aspartate, sir.
Non
Very good. N-methyl D-aspartate. Excellent. So that receptor, what does it do? When you activate, which is the ligand which will activate that receptor, NMDA receptor?
GABA effect.
Hey,
Calcium, sir.
you were answering very well. Now you are making a mistake. It's not GABA. GABA is for GABA receptor. NMDA glutamate. Glutamate is the receptor, ligand for the receptor.
Glutamate.
And when the glutamate is stimulating it, it prevents the calcium entry into the neuronal cells. So by blocking that action, you can see make it have the desired effect. And ketamine also can interact with opioid receptors. That is how it produces good analgesia, especially with the mu and kappa receptors of the opioid receptors. It acts, and so the excellent analgesia you get is because of this. and it has an antagonistic interaction with monoaminergic, muscarinic, and nicotinic receptors. That is why you get so much of salivation, secretion of all the methylphenidate 3 because of that, even though it produces anticholinergic symptoms also, which result in tachycardia and bronchodilation. So these are all the 4 mechanisms you have to remember, mainly NMDA, then opioid receptor, then action on the acetylcholine receptors, namely muscarinic and nicotinic, and also monoaminergic, and it has got an anticholinergic effect also. At a high doses, it has local anesthetic properties, and it may inhibit the neuronal sodium channels also. That is why it is used as a sole anesthetic in the intrathecal space. You can give preservative-free ketamine as a sole anesthetic for surgery, which will be effective for about 45 minutes to 1 hour. You inject 50 to 70 milligram preservative-free intrathecally. Okay, so people have done surgeries using that without the patient feeling any pain. Next comes etomidate, little rarely used with drug. So what is the chemical nature of etomidate?
It is a carboxylated imidazole.
Imidazole derivative, excellent. It's an imidazole derivative. How does etomidate affect the steroid synthesis? It is one of the main complications why this drug is not very popular is it can suppress the steroid synthesis. So how can it produce that effect?
It inhibits the enzyme 11 beta hydroxylase.
Excellent, excellent, excellent. It binds to P450 enzyme 11 beta hydroxylase, which is important for steroidogenesis. So that is how it is able to produce this. This effect is due to binding of a nitrogen atom in etomidate imidazole ring to the iron within the heme ring of 11 beta hydroxylase enzyme, resulting in the inhibition. So this is the vial in which it is available. It is available at 20 milligram in 10 ml. That is 2 milligram per 1 ml. What is the dose? Induction dose?
0.3 milligram.
0.3 milligram. Excellent. Excellent. What other imidazole derivative drugs are used in clinical practice? Metronidazole, most of the antifungal drugs, and even midazolam, they are all imidazole derivatives. Okay. What is the induction dose? Of course, 0.3 milligram. How is it metabolized in the body?
Hepatic hydrolysis.
By non-specific hepatic
hydrolysis.
esterases and plasma cholestases, hydrolyze etomidate to ethyl alcohol and carboxylic acid metabolite.
Carboxylic acid.
What are the unwanted side effects of this drug?
Proconvulsant effect in CNS.
Myoclonus and hiccups, sir.
Excellent.
Myoclonus.
First and foremost, as you inject, what will the patient complain of?
Pain on injection.
Pain on injection. That is the first and foremost. Just like your propofol, it can produce pain on injection, excitatory movements. It can also precipitate porphyric crisis. It can cause nausea and vomiting. Okay, so the excitatory movements is mistaken for convulsions. Okay? So these the 4 things you remember. Pain on injection is the first one you have to say, and excitatory movements are unwanted movements, jerky movements, porphyric crisis, nausea, and vomiting. Now coming to the analgesics, what is the difference between an opiate and an opioid? An opiate are all naturally occurring substances which have morphine-like properties. So if you morphine, diamorphine, all these things, you call them as opiates because they are naturally occurring, extracted. What is the plant from which morphine is obtained?
Poppy plant.
Papaver somniferum. Not erythroxylum coca. It is cocaine. Okay. Opioid It's a synthetic substance. So opiate is a naturally occurring morphine-like substance. Opioid is a synthetic substance that have affinity for opioid receptors. Describe a opioid receptor. What type of receptor is a opioid receptor?
Mu, delta, kappa, all are opioid
No,
receptors.
they are some forms of opioid receptors.
G coupled protein receptor, sir.
They are G protein coupled receptor located throughout the CNS, but more in nuclei of tractus solitarius, periaqueductal gray area, cerebral cortex, and thalamus. They are also located in the spinal cord, GI tract, and peripheral afferent nerve terminals. That is the reason why nowadays we add opiates, morphine or buprenorphine to the local anesthetic to prolong the action, because they are present in the peripheral afferent nerve terminals also. And the subtypes are 3, mu, kappa, and delta. Okay, so if they ask what are all the subtypes of opioid receptor, we have to say mu, kappa, delta. But if they ask them what type of receptor or what is the category of receptor under which they come, we have to say it is G protein coupled receptor. And why their names were given as mu, kappa, and delta, the subtypes? Because they were named using the first letter of the first ligand which bound to these receptors. When they did the research of trying to identify the opioid receptor, they found 3 ligands which were attached to these receptors. So mu stands for morphine, M. Kappa stands for ketocyclozone, and delta stands for it is found in the vas deferens of the rats. So that is why it's called delta. So how do the opioids work? How do they produce their analgesic effect? Okay, they act via G protein coupled receptors stimulated in the presynaptic area by closing the voltage sensitive calcium channels, stimulation of potassium efflux leading to hyperpolarization of the cell membrane. Whereas your thiopentone, how does it cause hyperpolarization? Acting on the GABA receptor. Is by
Increase the
chloride
duration.
condensate. So
Opening of
chloride is a negative ion
Chloride.
made into enter the cell. So if it goes into the, if you put too many negative ions inside the cell, you will cause hyperpolarization. Or if you drive out too much of positive ions, again you will lead to negativity. So hyperpolarization means extreme negative cell membrane potential. That is hyperpolarization. So that can be produced by pumping in more chloride, which is a negative ion by itself, or driving out more positive ion from inside the cell, you will result in hyperpolarization. Okay, so that is the main mechanism by which it acts in the presynaptic area. So it forces the voltage sensitive calcium channel. Calcium is a positive ion. It is not able to enter. And you drive out potassium, which is again positive. So you don't allow a positive ion to come in, you drive out positive ion, then the cell becomes hyperpolarized, not by entry of chloride. And it also reduces the cyclic AMP, which reduces neuronal excitability and transmission. So these are the 2 mechanisms by which opioids work. So if they give you or talk to you about opioid, nowadays this terminology, opioid-induced hyperalgesia is a very, very commonly used term, especially in chronic pain or cancer pain. When patients are treated with morphine, they develop this problem. So they may ask you about opioid-induced hyperalgesia. What is the answer for this?
Opioid-induced hyperalgesia is a condition in
Hmm.
which when the infusion of the drug which has like remifentanil is stopped, so the effect is gone immediately and patient will complain of pain after the immediately stoppage of the
Only
infusion.
remifentanil. Any patient who is already on opioid treatment, if he complains of severe pain in spite of being on opioid, that is called opioid-induced hyperalgesia. So it's a state of nociceptive sensitization caused by exposure to opioids. Okay, and it is a paradoxical response. where patient receiving opioids for treatment of pain may actually become more sensitive to certain painful stimuli. Okay, so they become or express more pain when they are on treatment with opioid itself. That is called opioid-induced hyperalgesia. If you answer this point correctly, one more question will be asked. How will you treat a patient with opioid-induced hyperalgesia?
Ketamine is
Excellent. Ketamine is
which has got a
outstanding.
role in opioid-induced hyperalgesia.
Fantastic. Very good. You are through. You are passed the exam. What are the preparations of morphine available? Various strengths of morphine. I don't know how many of you are familiar with this drug because
Oxmorphine.
It is available as 10 milligram per ml in a 10 ml vial. It is available as an ampule. It is available as tablet. It is available as a, what is this?
Patch and powder.
This is a dermal patch. So you can apply it to the skin also. So all the preparations are available. Vial preparation for larger doses, single dose ampules. Then you have tablets. Then you have cutaneous patches or dermals or patches are available. And these are all the various strengths. You may get 4 milligram in 1 ml, 8 milligram, and 10 milligram. All these things mainly for oncology use. Patients in terminal cancer, when you want to give palliative treatment, they require more and more morphine because they become tolerant to the drug. So all the higher concentrations are mainly used in the oncology practice. What is the oral dose of morphine? Morphine is given as a tablet for chronic intractable cancer pain. So 5 to 20 milligram every 4th hourly is the oral dose. Starting from 5 milligram, you can go up to 20 milligram, and every 4th hourly it can be repeated. So a maximum of 80 milligram per day can be given. What is the parenteral dose? It's 0.1 to 0.2 milligram per kg. IV or IM. What is the intrathecal dose and what preparation to be used? Sometimes you give intrathecal morphine for prolonged postoperative pain. So you have to use preservative-free morphine, and the maximum dose you can use is 1 to 3 milligram if it is intrathecal. I mean 1 milligram if it is intrathecal, 3 milligram for epidural. Okay, so that is the range. What are the features of morphine overdose? Supposing a patient takes or you have prescribed 20 milligram per day and it becomes an overdose for a frail patient. What will be the features of morphine overdose? How will you identify if a patient is brought unconscious to the ER with the history of morphine overdose? What are all the clinical features you will find in them?
The patient can have respiratory depression, meiosis, there will be constipation, there will be pruritus, urinary retention, and patient can have
slow, shallow, or complete cessation of breathing. So the respiratory rate may be only 4 to 6 per minute, and it will be deep and shallow. Persistent sedation will be there, unresponsiveness to painful stimuli, or sometimes they may have vivid dreams or hallucination. They may be delirious also, muscle twitching, myoclonus. They may have hypotension, pinpoint pupils, and slow erratic pulse. They may be cyanotic or pale, and vomiting may be there. Okay, so constipation and pruritus, all these things are not exhibited because majority of the patients will be unconscious. So these are all the main symptoms we have to describe. Now this is another drug which you are very commonly associated with. What is fentanyl? What is the chemical nature of fentanyl?
Phenylpiperidine derivative.
opioids.
Phenylpiperidine. It's a synthetic phenylpiperidine derivative. Very good. Okay. What sort of fentanyl is used?
Fentanyl citrate. Fentanyl citrate, sir.
Excellent. Fentanyl citrate is the salt. Excellent. And it is available as 100 microgram in 2 ml or 50 microgram per ml in the ampules which are available. There are also 10 ml ampules which are available for major cases. What are the routes of administration of fentanyl?
Can be administered IV,
I-
intramuscularly, orally, transdermally,
Intrathecal.
intranasally, all
Intrathecal.
routes.
Fentanyl, I am not sure. IV, intrathecal, and transdermal. So this is the transdermal patch, urogesic, 50 microgram per hour. Supposing you want to use this patch, when will you apply? Supposing you want to give this as a post-op pain relief for TKR surgery, when should you apply this patch? Is it before starting the surgery or after post-operative? How much time will it take to start the effect if you apply a transdermal patch? It will take 4 to 6 hours. So you have
4
to
to 6.
apply well in advance. Okay. What is wooden chest syndrome and why does it happen?
Wooden chest syndrome is a
Rapid
condition
injection
of
of fentanyl.
extreme, yeah,
So
it is
wooden
a
chest syndrome or chest
extreme
wall
rigidity of the
rigidity
chest, sir.
causing difficulty in ventilation. Okay.
Breathing.
And chest wall skeletal muscle rigidity is the result of fentanyl bound to mu opioid receptors on the central nervous system and the activation of dopaminergic pathway. That is the explanation for the wooden chest. How is it managed?
Sir, sometimes succinylcholine is required to break this chest wall rigidity, sir.
Okay. Actually, management of the syndrome can be done with naloxone, or you can use neuromuscular blocking agents like rocuronium. Okay, you straight away intubate that, or you can use stop the fentanyl infusion if you are using it in an infusion form. Tramadol, another common drug which you are using very frequently. What is tramadol? Always try to know the chemical nature of the drug. That's very, very important in the examination. It's a cyclohexanol derivative and it is a racemic mixture. Cyclohexanol derivative. How is it presented? Under all the preparations you have.
50 milligram per m.
It is available in 1 ml, 2 ml ampules. Also, tablets are available. So, oral tablets and paracetamol for IM IV uses. What is its mechanism of action? Is it the opioid?
It inhibits reuptake of
Agonist at all, it is an agonist at all opioid receptor, but it is not a classified drug like opioids. So it can be purchased without a narcotic license. So all opioid receptors, especially mu receptors, it also inhibits the reuptake of noradrenaline and 5-hydroxytryptamine and the locus coeruleus. What are its interactions? What is one contraindication for usage of tramadol?
Seizure.
Very good. A patient with who are on tricyclic antidepressants or who are already known epileptics, better to avoid tramadol. Okay. So psychiatric patients taking tricyclic antidepressant or selective serotonin reuptake inhibitor drugs, they are taking those drugs, avoid tramadol because even if they are not epileptic, it can produce seizure in those patients. Or if the patient is already a known epileptic, it will reduce the threshold for seizure activity. So avoid tramadol in patients with known epilepsy. It's contraindication not to be used in patients suffering from epilepsy. How does tramadol help in controlling post-operative spinal shivering, or for that matter, any shivering? What is the mechanism? It is commonly used to control post-spinal shivering.
7.
Again, by the prevention of reuptake of
No.
norepinephrine, serotonin, and activating the descending inhibitory pathways. Okay, so inhibitory pathways are activated. That is how it produces the anti-shivering. Now, coming to NSAIDs, which we commonly use, paracetamol. Every one of you must be using it right, left, and center. So you must be knowing everything about it. So this is the preparation that you have. What is the composition of this paracetamol infusion? What all the ingredients are there in this? I'm sure every one of you must be using it every day in your practice, in your training. Okay.
Along with
Each
mannitol.
100 ml contains 1000 milligram paracetamol in 100 ml. That is 1 gram. This is 1 gram bottle, which is marketed as 100 ml. It contains cysteine hydrochloride monohydrate, disodium phosphate dihydrate, hydrochloric acid, which is for pH adjustment, and sodium hydroxide, again for pH adjustment, mannitol and water for injections. So remember, 1 cysteine hydrochloride monohydrate, 2 disodium phosphate hydrate, 3 hydrochloric acid, 4 sodium hydroxide, and 5 mannitol, and base is water. Okay. So what are these things called? Cysteine hydrochloride monohydrate, disodium phosphate hydrate. These two they have mentioned it is for pH adjustments to make it acidic. Hydrochloric acid and sodium hydroxide make it. Any drug which is marketed as a liquid should be in the acidic pH. Then only it will have a long shelf life. All drugs which have alkaline pH should be marketed as powder to have a long shelf life. So most of the drugs are all acidic. Whatever you take, all liquid preparation drug will be only having an acidic pH like 4, 4.5, 3.5 like that. Whereas what are these cysteine hydrochloride and disodium phosphate do? They are called excipients, which give volume. Okay, so they are called excipients. So how are prostaglandins synthesized? Whenever you talk about NSAIDs, you must know how prostaglandin is synthesized in the body. Can you say the steps of prostaglandin synthesis? What is the base from which it is? So membrane phospholipids acted upon by cytosolic phospholipase A2 is converted into arachidonic acid. Arachidonic acid is acted upon by cyclooxygenase 1 and 2, and also another enzyme which is not mentioned here. What is that enzyme? So arachidonic acid is acted upon by 2 enzymes, cyclooxygenase subtype 1 and 2, as well as another enzyme. Can you name the other enzyme? Lipooxygenase. Okay, there are 2 enzymes which act on the arachidonic acid. You will know why I am talking about lipooxygenase in a few short while. So the cyclooxygenase prevents the conversion of, or helps in the conversion of arachidonic acid into the various prostaglandins, prostaglandin G2, H2, I2, all these things, and also thromboxane A2. Okay, all these things are produced by that. So by blocking the action of this cyclooxygenase enzyme, you can prevent the formation of prostaglandin. That is how the NSAIDs act. Now the other enzyme, lipooxygenase, produces what is called leukotrienes. Okay? These leukotrienes are responsible for bronchospasm. So whenever you use NSAIDs, you are not supposed to use them in asthmatics because you are blocking only the cyclooxygenase, which is preventing the formation of prostaglandin. But leukotrienes are not blocked, and they produce a lot of leukotrienes, which will stimulate or cause bronchospasm. Okay, so that is the mechanism of bronchospasm produced by NSAIDs. Can paracetamol be called as an NSAID? Strictly speaking, paracetamol is not considered an NSAID because it has got very little anti-inflammatory effect. The main action of NSAIDs is anti-inflammatory. It is why you use it in rheumatoid arthritis, osteoarthritis, all painful conditions. More than alleviating the pain, it also reduces the inflammation produced by these prostaglandins. So, but paracetamol does not have that much of an effective anti-inflammatory effect. It mainly marks only cyclooxygenase, the central nervous system, but not in the rest of the body. What happens in paracetamol overdose? In UK, paracetamol overdose is the main cause for acute liver failure.
Acute hepatic failure.
So how is it caused? So how is paracetamol metabolized in the body? If you know that, you will know the answer for this. What are all the routes of elimination of paracetamol? Okay, right. Acute liver failure can happen due to one compound formed NAPQI. What is the expansion for that?
PQI.
It is toxic to hepatocytes. What is the expansion for NAPQI? N-acetyl parabenzoquinoimine. Very difficult to mention that. So acetaminophen, that is paracetamol, which you take either by parenteral or oral route. There are three routes of elimination. Two routes are called conjugation. It can combine with glucuronic acid and it will become a non-toxic moiety. It can combine with sulfate and again it will become non-toxic. But when it is metabolized by P452E1 enzyme, it is converted into a compound called N-acetyl parabenzoquinoimine. This is NAPQI, which is toxic. This has to be made into non-toxic by combining it with glutathione. Okay? This glutathione stores will be exhausted when you take overdosage of paracetamol as a effort to kill yourself. So this glutathione store will be exhausted and this NAPQ will remain as an NAPQ instead of getting converted to cysteine and mercaptic areas which are non-toxic. So patient will immediately develop acute liver failure and die. When you give N-acetylcysteine, it will replenish or replace the availability of glutathione and prevent you from going in for hepatic toxicity. Okay? So remember these three modes of elimination of acetaminophen: conjugation with glucuronic acid, conjugation with sulfate, and conversion to N-acetyl P-benzoquinoimine by this P450 enzyme. What are the side effects of NSAIDs and how are they caused? This is a very, very common question. How do they produce the renal failure? How do they exacerbate the gastric ulceration? This is a very common question you will get in the exam.
Pre-renal vasoconstriction. Pre-renal vasoconstriction due to prostaglandin inhibition.
Renal. Doesn't cause renal.
Acute
The main effects of NSAIDs are renal failure, aggravation of gastric ulcer, bleeding, and aggravation of asthmatic attacks. These are the four important side effects. And blocking of prostaglandin production results in renal damage by causing renal inner medullary ischemia. This is very, very important because the blood supply to the kidney is divided 80% to the cortex, 20% to the medulla. Out of the 20% going to the medulla, 15% goes to the outer medulla and only 5% goes to the inner medulla. And that inner medullary 5% of blood supply is dependent on the presence of prostaglandin. And when you give NSAIDs, that 5% supply is also completely blocked because prostaglandin is not available. And in addition to that, it may also produce what is called interstitial nephritis. The medullary interstitial nephritis inflammation also can happen. So by these two mechanisms, it doesn't act on the renal artery directly. Please don't mention that answer at all. It doesn't have any action on the renal vessels or the glomerular vessels also for that matter. It affects only the inner medullary blood supply and causes nephritis or inflammation in the interstitium, which is very important for maintaining the hypertonicity and producing the urine. And in the stomach, a mucus is always produced by stimulation of prostaglandin to give a covering to prevent the damage caused by the acidic nature of the gastric secretion. So when you block prostaglandin, this mucus production is also blocked. So patient stomach will be exposed to more acid, and if they already have an ulcer, that will be exaggerated. And blockade of thromboxane will lead to bleeding, and an unopposed action of leukotrienes, as I said earlier, will cause aggravation of asthma. So these four important pathological mechanisms you should be able to answer. This is diclofenac, which you are regularly using, 75 milligram per ml, which is available as a ampule of 3 ml and 1 ml also nowadays. And this is suppository. It is administered as a suppository, and you have two strings in that, 12.5 and 25. So how do you classify the NSAIDs? Sometimes they may ask you this question also. How are NSAIDs classified? So this is the classification. They can be non-selective cyclooxygenase inhibitor. They can be preferential cyclooxygenase 2 inhibitor. They can be selective cyclooxygenase 2 inhibitor.
Selective.
And analgesic with antipyretic or poor anti-inflammatory action like paracetamol, metamizole, ifopam, all these things. So cyclooxygenase 2, nimesulide, diclofenac, aceclofenac, meloxicam, todolac, all these things are. Nimesulide, of course, has been now banned. It is not available. All the other things are still available and in some use. And this talks to selective inhibitors like celecoxib. Some of them are also have been banned because of cardiac complications. Okay, and the category like non-selective, you can say aspirin. They are all derivatives of various acids: acetic acid, propionic acid, and enolic acid. So many acids are there, and pyrazolone and penmate derivatives. So they are all available. Indomethacin. Anybody who can say what is the recent indication for indomethacin?
It is your patent ductus arteriosus.
Very good. That is old indication. I am asking about recent indication. Approved by ICMR, Indian Council of Medical Research, for a pandemic that we had now. It is supposed to be very good to control the COVID cytokine storm. This has been proved by one of our Chennai-based nephrologists, Dr. Rajan Ravichandran. He introduced it in the COVID first wave itself. Said it's a very cheap drug and very effective drug for controlling the cytokine storm. And it has now been approved by ICMR. 30 milligram twice a day is a fine. 5 days it will control the cytokine storm instead of using costly remdesivir and all other expensive drugs. So ketorolac is another drug. It is the tromethamine. The salt is ketorolac tromethamine. It is available as ampules and vials, and also for IM use, and IV and tablets are also available. So these are all the various things that are available. Coming to the local anesthetics, how are local anesthetic drugs classified? A common question.
Ester and amide, sir.
They are ester linked or amide linked. Okay. And again, under each category, we can say it is a long acting, short acting, or surface acting, or long acting and medium acting against the amides. So medium acting is lidocaine, long acting is bupivacaine, ropivacaine, surface action, benzocaine. These are all esters. So how to find out when a drug is given to you, whether it is an amide or an ester? Is there any way to find it out from the name of the drug or the spelling of the drug?
Sir, two eyes. Amides have two eyes, sir.
Yeah,
like
one eye.
lidocaine.
Yes, there will be one eye will be there in all the amide group of drugs. For example, lidocaine. Caine is common for all, whether it is ester or amide. CANE, caine is common. But if you take the first portion of the name, lidocaine will have I, bupivacaine will have I, ropivacaine will have I. Whereas if you take the esters, procaine, no I, tetracaine, no I, fluoroprocaine, no I, all these things are esters. So if you don't find an I in the first half of the name before caine, this is ester. If there is an I, it is an amide. So even if you have any doubt in the exam of a new drug, mepivacaine is an amide because I is there. So what is the metabolism of lidocaine? How is it metabolized? Okay, lot of time I am running. So metabolic pathway causes oxidative dealkalization in the liver into monoethyl glycine xylidide. This is the metabolic product, monoethyl glycine xylidide, and that is further metabolized to xylidide, hydrolyzed to xylidide. So ultimate end product of lignocaine is xylidide. So if they ask you in the exam, you can simply say it is converted into xylidide. And this monoethyl glycinide, which is an intermediate product, has 80% activity of lignocaine. So many of the drugs, when they are metabolized also, their metabolic products will also retain some of the functions of the original compound. So how does prilocaine cause methemoglobinemia? Where do you use prilocaine in your practice?
Amla cream.
Amla cream, excellent, fantastic.
Amla cream.
So how does prilocaine cause methemoglobinemia? Because it is produced metabolized to a drug called orthotoluidine, a compound called orthotoluidine, and that is the one which is responsible for methemoglobinemia. And what is the treatment for methemoglobinemia? And what is exactly methemoglobinemia?
Methylene blue, IV.
No?
IV methylene blue.
Methylene blue,
blue.
yes, ascorbic acid, both can be given. What is the difference between lignocaine and mepivacaine?
So lignocaine is a short-acting drug. Bupivacaine is a long-acting drug. Lignocaine is less
Not
cardiotoxic.
bupivacaine.
Bupivacaine is more cardiotoxic.
Mepivacaine.
Here
Mepivacaine,
it is not bupivacaine, it is mepivacaine. Please look at the question properly.
Okay.
Of course, mepivacaine also has a little longer duration compared to lignocaine, but the main difference is lignocaine is a good vasodilator, whereas mepivacaine does not have the vasodilating property. Okay, so mepivacaine has a somewhat longer duration of action, but mepivacaine lacks the vasodilator activity of the lignocaine. So how is bupivacaine metabolized in the body? Just like lignocaine becomes xylidide. This is also by N-alkylation, amide hydrolysis, conjugation, and hydroxylation. So 4 routes of elimination are there. And again, how ropivacaine is metabolized? It is by again hepatic cytochrome enzyme 450 into 5-4-xylidide. Again, this is just like your lignocaine. It is also converted to xylidide, and small fraction is excreted unchanged in the urine. What are the current guidelines by Association of Anesthetics of Great Britain and Ireland for management of local anesthetics? Systemic toxicity. Last.
So first we have to do maintain the airway, breathing, and circulation of the patient, and then we have to rule out is there anaphylaxis is there or not. And once we confirm that
first
it is
this is the guideline, 2010 recommended guideline: recognition, immediate management, treatment, follow-up. These are all the steps that you have to follow. Okay? And what is the toxicity ratio of local anesthetic? This is a very important point. Everybody should know. What is the definition of a toxicity ratio of a local anesthetic agent?
CNS to cardiac toxicity ratio.
CVS to CNS, not CNS. So plasma level of local anesthetic needed to produce CVS effects divided by the plasma level of local anesthetic needed to produce the CNS effect. Because CNS effect will come first, then only CVS effect will come. So you will require a larger dose for CVS effect compared to the CNS effect. So what is the value for lignocaine? What is the value for bupivacaine? What is the value for levobupivacaine? The toxicity ratio, this is the, for lignocaine it is 7, which means if you get a convulsion or perioral numbness, tingling, all these things with the lignocaine, you require another 7 times more plasma level to produce cardiac arrest. You understand? Similarly, with bupivacaine, when you get a perioral number, you require only 3 times more plasma level to produce the cardiac arrest. Whereas levobupivacaine is intermediary. Once you get the perioral numbness or tingling or seizure, you require another 5 times more plasma concentrations to produce the cardiac effects. Okay, so that is what is called the toxicity ratio. You require a higher dosage for cardiac complications compared to the CNS complications. What is the new methods to prolong the duration of action of local anesthetics? Normally, we add adrenaline, isn't it?
Adrenaline. Yes.
What are the new methods? So you can use, or you can use a liposomal encapsulation of the drug, or you can use a biodegradable polymer. Especially these are all after the idea came because of need for prolonged pain relief in cancer patients. So liposomal bupivacaine, liposphere bupivacaine, and site 1 sodium channel, which is called neosaxitoxin, or similar neurotoxins, which are called sodium channel blockers. What is rapid rescue for last?
Intralipid.
Intralipid. Give lipid emulsion 20%. What is the dose? 1.5 ml per kg over 1 minute IV bolus. Okay, first bolus is 1.5 ml per kg, followed by an infusion of 15 ml per kg per hour. A maximum repeat of 2 doses of 1.5 ml given at least 5 minutes apart if the patient has cardiovascular instability or is in cardiac arrest. So maximum 3 bolus doses totally. And increase the rate to 30 ml if hemodynamic stability is not restored after 5 minutes. So you start with 15 ml per kg. If still the patient is hemodynamically unstable, you make it 30 ml per kg. Continue infusion until hemodynamic stability is restored up to the maximum dose. Do not exceed maximum cumulative dose of 12 ml per kg. And base the dose on lean body weight in obese patients. Do not give the total body weight. So these are the 2 preparations of intralipid. Was intralipid introduced as a remedy for local anesthetic toxicity?
No, sir.
It was for total parenteral nutrition. Intralipid, these solutions were used for TPN, not for treating them, but they found that it is useful in local anesthetic toxicity. So there are bottles available and sachets available. These are the 2 preparations.
So there is one question. Sir, can propofol be used in emergency for local anesthetic systemic toxicity?
It will produce further depression of the central nervous system. How much
you
require a larger, very large dose. You can imagine 1.5 ml per kg means for a 70 kg man, you have to give almost 100 ml. Will you give 100 ml propofol? And that by itself it is a central nervous system depressant. Even though it has a high lipid content, it cannot be used.
Okay.
What is the structure of a sympathomimetic drug? So catecholamine is a base. Okay. Now can you identify what is this? This is a catechol ring. Okay. So the hydroxyl group is present at C3, C4. The base is a benzene ring, and there should be a hydroxyl group at C3 and C4. And what is this? Now you find this is the base. Again, hydroxyl is there, to which there is the, what is the NH2? All are good in chemistry. Then amine group which is added to that.
Amine.
This is C3, C4. This is C1, C2, C3, C4. So C1 position, if you add an amine, what does it become? It becomes dopamine. So amine is added to the catechol ring. So C1 position amide is added. Now what do you find here? What is extra from this one? This is the dopamine, then amine. Now you find one more
hydroxyl group.
So what does it become?
Norepinephrine.
Yes, norepinephrine.
Or
Another hydroxyl attached amine side chain. Now, what is added again? You find something new here.
methyl group.
Methyl group. Yes. So it becomes adrenaline. So if methyl group is added to the amine side chain, it becomes adrenaline. Without methyl, noradrenaline. Without hydroxyl group, extra hydroxyl group, dopamine, and basic benzene ring with 2 hydroxyl is catechol. So this is the catechol ring from which it is all produced. Okay. So that is the basic structure. How are sympathomimetic classified? Naturally occurring like adrenaline, noradrenaline, and dopamine. Synthetic like dobutamine, dopaxamine, isoprenylin, and other agents like aminophylline, milrinone, levosimendan, calcium, and thyroxine. Okay, so this is how the sympathomimetic drugs are classified into. So this is adrenaline. All of you would have seen 1 ml ampule. Now, what is the salt here? It's available for you to read. The adrenaline bitartrate.
Okay.
What other preparation or what other salt is available? Huh? What other salt of adrenaline preparation is available? You have adrenaline hydrochloride. Okay. So what is the difference? There are 2 preparations: adrenaline hydrochloride, adrenaline bitartrate. So what is the difference between the 2? This is synthetic. This is naturally occurring. Okay. Even adrenaline, when it is synthetically made, it is made as a bitartrate salt. When it is extracted from bovine adrenaline glands, it is extracted as an adrenaline hydrochloride salt. So adrenaline bitartrate is synthetic and hydrochloride is naturally occurring. What are the various uses of adrenaline in clinical practice? Very simple question. Quickly, can you answer?
Cardiac arrest.
Very good.
Cardiac
Ah, so
Anaphylaxis.
anaphylaxis 1 milligram, 2 to 3.
Anaphylaxis.
Excellent. Anaphylaxis second. Very good.
Anaphylaxis.
What is it? Anaphylaxis.
Bronchospasm.
Inotrope in ICU for nebulized acute
Acute
asthma,
bronchospasm. Non-responsive.
and to LA drugs for prolonged action. Okay. So this is NORAD. Okay. And what is the salt of NORAD? Here it is mentioned only sterile noradrenaline concentrate. But just like adrenaline bitartrate and adrenaline hydrochloride, what is the salt of
Bitartrate.
noradrenaline? Bitartrate. Very good. Excellent.
Bit.
So the type of infusion, what type of infusion set you require whenever you want to administer inotrope? Of course, all of you should be knowing the indication for noradrenaline use. It is the main drug for hypotension in sepsis, isn't it? So the rate of flow is calculated by drops per minute. What is
Drops
the
per minute.
TTTS per minute? Okay, in hospitals, intravenous tubing used to deliver medications are various sizes. You can get from 10 drops per ml to 60 drops per ml. Okay? Macro and micro sets, we call it as. A drop is abbreviated as DTT or DTT, S and DTT. It is a word derived from Latin. Gette means drop. Okay, so DTT per minute. You can write drops per minute, you can write DTT per minute. So ideal to use a micro drip which can deliver 60 drops per minute for a precise dosing. So what is this? This is the micro drip set. Okay, you can see the very sharp, small dropper here inside the drip chamber. Okay, so it will produce a very small drop. And this is a burette microset. Okay, so you can see the amount required, and you can see this again, a small thin dropper, which small drops will fall. Dopamine and dopamine comparison. What is the difference between dopamine and dopamine? First and foremost, already we have shown how to classify sympathomimetics.
So Tachycardia is
One
less
is-
with dobutamine in comparison.
So it is a natural, first of all, dopamine is naturally occurring and dobutamine is synthetic catecholamine. Okay. And dopamine more of adrenergic and plus dopaminergic and alpha beta, whereas dobutamine is pure beta, more beta 1 more than beta 2 more than alpha. And of course, the increase and sustain neutral drugs. So sometimes they can ask you to compare all these things when they are useful. How these drugs are marketed? What are the presentation?
Intravenous injections.
Dobutamine is available as 250 milligram per
Powder.
20 ml. Okay, so it's the vial contains 20 ml, 250 milligram, and it's also available as a powder, lyophilized powder, which can be reconstituted again 250 milligram, and it is also available in ampoules. Whereas dopamine is 200 milligram in 5 ml ampoules. Okay, that is the difference. Here it is 250 dobutamine. Dopamine is only 200. How to calculate the exact dose? That is another question that can be asked. Another rare drug which they can ask you is digoxin. What are the indications for the use of digoxin? And what are all the preparations you know of? It is very rarely used by cardiologists. In olden days, it is the drug of choice for mitral stenosis and
Cardiac
progressive heart
failure.
failure patients. Okay. So it is available both as the tablet as well as injection, 500 microgram or 0.5 milligram in 2 ml or 250 microgram. When will you use the injection? When will you use the tablet? There are two preparations. What are the indications for their usage? Rapid digitalization. If you want to rapidly digitalize the patient, you have to go for injection. For slow digitalization, you can give it orally. Start with 0.25 milligram once a day for 5 days a week, 2 days you have to abstain. Okay, that is slow digitalization. What is the mechanism of action of digoxin? This is one of the common questions they may ask you. Especially if the drug is kept in the tray of the other drugs that are kept in Viva, they may suddenly ask you. If you answer this, you are likely to get very good marks. So it acts on the two channels in the nerve cells. One is the sodium potassium ATPase pump. It blocks that pump so that what happens, there is sodium retained inside. Okay. Normally, this pump will try to push the sodium out and bring potassium inside. Okay. 3 sodium molecules will be pushed out to 2 potassium molecules. Isn't it? So here what happens, by blocking the pump, it allows the sodium to accumulate inside. Once the sodium level becomes high inside, there is another pump called sodium calcium exchanger. So what will happen, the concentration of sodium inside the cell will become higher than the interstitial or outside. So what will do, it will try to go out and replace it with calcium. Whenever calcium increases inside any cell, it will combine with the troponin C, which is the calcium binding site, and it will increase the actin myosin complex and increase the ionotrophy. Okay, that's the mechanism of digoxin. And another mechanism of rate control is by increasing the vagal activity. So whenever the vagal tone is increased, AV conduction is decreased, and rate is decreased. So it increases the force, decreases the rate, thereby increases the cardiac output. This is another rare drug, isoprenaline. Sometimes they can keep you keep this and ask you. It is a 2 milligram per ml ampule. It is a synthetic, non-selective beta adrenal receptor agonist, very much analog of epinephrine or adrenaline. So, what compound is this? Is it isoprenaline? I showed this picture earlier. I want to see how many of you are very attentive and able to find out.
Adrenaline.
This is adrenaline because there is a methyl group here.
Adrenaline.
Okay? So one position there is a amine ring with hydroxyl as well as methyl group. This is adrenaline. Whereas This one is isoprene. Without the methyl group, it is a isoprene. So what are the indications and contraindications for the use of isoprene? When will you use isoprene? Mainly when there is a severe bradycardia, not responding to your atropine, glycopene and all the things. So used in the treatment of bradycardia due to excess dose of beta blocker or heart block, or rarely for asthma because it can produce bronchial dilatation also. And it should not be used in tachyarrhythmias or tachycardia, heart block caused by digital poisoning, and also not to be used in ventricular arrhythmias or in patients with angina. What is the half-life of isoprene? How long it can act? It's a very short-acting drug, approximately 2 minutes. What is the dose? Again, it's a bolus. It can be given as a bolus as well as an intravenous infusion, 0.2 milligram, 0.02 to 0.06. That is the dose of infusion. What is this? Dopadic. All other things are not very clear. I purposely selected this picture. This is dopexamine. Okay? It's a synthetic analog of dopamine again. So isoprene is a synthetic analog of adrenaline, whereas dopexamine is a synthetic analog of dopamine. So it is presented as 50 milligram in 5 ml ampoules. Mechanism is stimulates beta cell receptor. Okay, come again. I will just go. Okay, thank you. So its uses are used to improve cardiac output and it improves the mesenteric perfusion. The dose is 0.5 to 6 microgram per kg, the range. And half-life is 7 minutes. And potentially hazardous to use it with MIO, monoamino oxidase inhibitors, which can result in hypertensive crisis. And in beta blockers, it can cause severe hypertension. Sympathomimetics, it can cause action will be enhanced. Now, adenosine, this is another common injection that they can keep in the exam. What is it used for? What is adenosine, first of all? Supraventricular tachycardia indication. What is it, first of all? What is the chemical nature of adenosine? It is a naturally occurring purine nucleoside. What is the difference between a nucleoside and a nucleotide? And where is this nucleoside used? Nucleus side. And the formation of RNA and DNA. Adenosine is one of the 4 nucleoside building blocks for DNA and RNA, which are essential for all life. And the difference between nucleoside and nucleotide is nucleoside is a nitrogenous ring with a sugar, pentose sugar. If you add one phosphate to that, it becomes nucleotide. Okay, so without phosphate, it is nucleoside. With phosphate, it is nucleotide. And what are the uses? The treatment of SVT and also for finding nuclear stress test as an adjuvant to thallium. What does it do? What is the mechanism of action? It causes there's an adenosine receptor which is there, A1, A2, 3, increases potassium efflux, decreases calcium influx, and thereby hyperpolarizes the cardiac muscle. Again, I told you, you pump out calcium, you prevent calcium, potassium, to prevent calcium entry, you will cause hyperpolarization. So by that, it is able to reduce the rate, mainly in SVT or other supraventricular tachyarrhythmias, and it can be given as an IV injection, and half-life is only 2 to 10 seconds. The symptoms will do that, flushing, chest pain, and that unwanted asthma will get exaggerated, and it is metabolized by the spaces in the RBC. That is the range feature. Ethanol is a very common drug. Adenosine also causes vasodilation in majority of the coronary, hepatic, all these areas you will know. But where does that adenosine cause vasoconstriction? See, coronary artery, when the demand increases, adenosine causes coronary vasodilatation. Similarly, hepatic arterial buffer response, it causes vasodilatation in the hepatic artery. Isn't it? So, but one condition, one organ, it causes vasoconstriction. Okay? Renal artery, it causes vasoconstriction. Adenosine. Okay? Esmolol, what is esmolol? It's a cardioselective beta blocker. It is for blunting hemodynamic response to laryngoscopy, one indication. Can you tell me other indications? Episodic atrial fibrillation for control of ventricular rate. And to reduce the heart rate and BP during beating heart CABG. And the surgeon wants the heart rate to be slow, you can use esmolol. And you can terminate supraventricular tachycardias also with SVT. Why the name esmolol is given to that and how is it relevant to its metabolism? Actually, it is a ester methyl group. So that ES and M has been taken and esmolol is named after that. It's chiefly metabolized by the esterases in the red blood cells and not by plasma cholinesterase like your succinylcholine. What is the dose? The loading dose of 0.5 milligram per kg is given, followed by infusion of 0.05 to 0.2 milligram. Amidrone, this is another common drug they may ask you. It is available in so many forms like ampules, vials. Amidrone is a, what is this? Derivative. Acts by blocking potassium channels. What, under what category of antiarrhythmic agent amidrone comes? Class 3, class 1, class 2. One use the classification. Okay, class 3 antiarrhythmic agent blocks mainly the potassium channels, but also blocks sodium and calcium channels. Its uses are the treatment of SVT, ventricular tachycardia, WBC. So you can use it for both atrial fibrillation and ventricular fibrillation and tachycardia. So one drug common to all types of arrhythmia. The dose is 5 milligram per kg over 1 hour, followed by 15 milligram per kg for 24 hours. Side effects are, so many side effects are there. It is remembered by this mnemonic 2P, 2L, 2AC, thyroid abnormality, photosensitivity, peripheral neuropathy, lung fibrosis, liver damage, cardiac depression, corneal microdeposits. All these things are the side effects. NTG, this is another commonly used drug. What is the mechanism of action? Produces nitric oxide, activation of coronary guanylate cyclase, increase in cyclic AMP, and acts by two mechanisms: decrease calcium influx or decrease the release of calcium from the endoscopic the sarcoplasmic reticulum. So there is a decrease in the cytoplasmic calcium, coronary relaxation. What are the effects are mainly venodilator, causes a reduction in preload, decreases wall tension on oxygen demand, which causes a tolerance to the what causes tolerance to nitrates? Is the depletion of sulfhydryl group within the vascular smooth muscle, which causes this problem. How can tolerance be prevented? You can stop the drug for a few hours or infuse acetylcysteine. Acetylcysteine earlier we saw is used for treating the paracetamol overdose. The same thing can be used here also for supplying the sulfhydryl group in this poison. Okay. So I will stop here because I have an engagement at 6:30. We will continue with that in the next class. Any questions?
Thank you, sir. Thank you, students. Any questions?
You can mail me or you can contact me later in the next class. Okay?
Yes, sir.
Okay, sir.
Thank you.
And there is a very good response in
Thank
the
you,
YouTube channel also, sir. Within hours of uploading the recording of our session in the YouTube channel, we get more than 150 views, sir. People are very much interested.
Okay.
But most of them are not reflecting back, that they are not putting comments or queries or suggestions. Maybe they are afraid or hesitating.
No, that hesitation and fear should go. You should be bold enough to ask questions or clear your doubts. And that can also expose my weakness also. If I don't know the answer, I will go and read. Okay. So both ways it is beneficial.
Yes, sir. So can I add one more point, sir? Like adenosine being a natural substance,
Nucleoside.
it is involved in angina also. Actually, it is a co-substance released during myocardial ischemia, and substance P causes pain. This adenosine reduces the heart rate, so heart gets myocardial oxygen balance.
So one of the important mechanisms, coronary augmentation of coronary blood flow happens because of basically metabolic demand. When it increases, adenosine is the one which causes coronary vasodilation to meet that demand.
Yes.
Normal health itself. That is similarly in the hepatic also it causes the increase in blood flow by dilatation. But in renal artery, afferent arteriole, it causes vasoconstriction. That is a different method.
So in any way, it is having a problem in post-renal transplant cases, sir?
No. Not if you don't use. We are not commonly using adenosine, 15 leaf or any exogenous adenosine is not being used.
Okay.
It's a natural nucleoside ligand which is available.
Okay, sir. Thank you, sir. Thank you.
Thank you very much.
Thank you very much, respected professor. And we'll be having our next class on, sir, after 20.
Yeah, I'm back only on 27th next week for my station trip. So we'll have to have it on 31st if possible.
Yes, sir. 31st is Tuesday. Okay.
Okay, thanks.
Okay, sir. Thank you, sir. Thank you so much, sir. With your kind permission, can I sign off this meeting, sir?
Okay, bye-bye. Thank you.
Thank you, sir. Happy journey, sir. Thank you. Thank you, dear students.
Thank you.
Thank you so much.